Hello, everyone. Welcome to Osteoporosis Canada's webinar. We're just going to give a few minutes here, and then we're going to get started. So while we're waiting for people to sign in and get ready, I was going to share an overview of the FLS Hub website. And it is located on the Osteoporosis Canada website. And you can see our address located on the screen in the blue font. So please feel free to explore that whenever you'd like. In addition to webinars, the FLS hosts a variety of resources, including an informative toolkit, and we also maintain a registry of all FLS sites in Canada. We send out a regular newsletter, and we're more than willing to support any sites who are hoping to start a new FLS. We also have many of our resources available in French. So we are going to get started in a minute, and we're pleased to be joined by Dr. Diane Theriault. She's the Chief Scientific Officer for the Osteoporosis Canada, and she's going to talk to us about FLS implementation in Canada and where we are at now. If you have any difficulties with the chat box, with the technology, please let me know through the chat box. If you can't hear anything through your computer speakers, you can also use that call-in number in Canada to call in, and you'll be able to hear over the phone. If you have any questions today, please feel free to put them in the question box at the bottom on the right hand of your screen, and I will do my best to pass them along to Dr. Theriault so she can answer them. Also, any questions that you don't get asked today, then you can send it to me over the survey that's going to come to you in a minute. Okay, so Diane, I'm going to give you the floor, and you're going to have a link that you should be able to join us. And yes, I can see your slides. So if you could just begin your slideshow. Yep.
All set. Can you hear me okay?
I hear you fine.
Okay, so thank you for attending this webinar. This is our opportunity to give an update on the status of FLS within Canada. So what I'm going to cover today is I will very briefly go over the post-fracture care gap. That's well covered in two other of our webinars that are posted online. I will also go over some of the interventions that do not work to close this care gap. I will focus on the one and only solution that fixes this care gap, which is the fracture liaison service. But I will only give very brief details on that because we have other webinars on this posted on our website. And then I'll focus on the Osteoporosis Canada FLS Registry and look at the challenges to implementing FLS within Canada. So after that first fracture, we know that the risk of a second fracture is high, but on top of that, it's also very imminent. So typically, the highest risk is within the first 1 to 5 years after that broken bone. How high is it? Well, after a broken wrist, you can see that close to 15% will come back with a new fracture within the next 3 years. And that this fracture group is a very diverse group. So some of the patients will break again in the next year or two, but some, their next fracture may not be until the next 40 years. So quite obviously, this is a group that a bone density assessment is very important in order to determine that patient's fracture risk and whether or not they would benefit from the addition of osteoporosis treatment. But that is not the same for all fractures. After a broken bone in the spine, 1 in 5 will break another vertebral body within the next 12 months. This is a huge risk. And if we look after that first spine fracture, what's the likelihood of the patient returning with any other fracture within the next 2 years? That's close to 1 in 2. It's a very, very huge risk, and we don't need a bone density test in this instance to know that the patient would benefit from osteoporosis treatment. And by the way, this is not controversial information. This is consistent in all national and international guidelines that I published. What about the broken hip? Well, that is the queen of all fractures in terms of predicting future fractures. As you can see, after you break this first hip, there's close to a 1 in 10 chance of breaking the other hip within 12 months. And there's a 20% chance of breaking the other hip within the next. And if you don't come back with a broken hip, there's a very good chance that you'll come back with another broken bone within the next 5 years. So quite obviously, this is another group where there's no controversy. A fragility fracture after of the hip after the age of 50 in all national and international guidelines. That is a group that is indicated for osteoporosis. So quite obviously, the risk of second fracture is really high, and it is imminent, but this is particularly so for the broken hip and the broken spine. So what do our guidelines say? Well, quite obviously, this is an important component of the guidelines. Our guidelines are evidence-based. So fragility fracture after the age of 50, something needs to happen regarding osteoporosis. And the recommendation is patient needs to have a bone density test or should be offered treatment. And the purpose of doing a bone density test is to determine the patient's stature. And here's something else that we have in our osteoporosis Canada guidelines. If the patient is at high risk, then they're highly likely to benefit from osteoporosis treatment. So our guidelines say high risk treatment. So if we look at the fracture types that are most likely to come back with repeat fractures, we call them major osteoporotic fractures. The World Health Organization specifies the hip, the spine, the wrist, and the shoulder. The Public Health Agency of Canada does surveillance of fractures and has selected 5 fracture types which they consider as major osteoporotic fractures because of their repeat incidence of future fractures. So for the purpose of this, the rest of the slides here, we're going to use the Canadian Public Health Agency of Canada fracture. So the other thing that's important to understand is we're going to improve the system. We need to have them obtain the care they need, which is ability. They need a BMD and or treatment. Because the osteoporosis medications are effective, the fracture rate of 50 to 70% within the first year that we start on. Then we should be able to see in that group of patients a decreased number of fractures, including a reduction in the number of hip fractures. Because hip fractures are have very poor prognosis, so there's a high mortality risk. If we're able to reduce hip fractures, we should be able to reduce mortality, and we should be able to reduce healthcare costs because hip fractures cost over 60,000 Canadian dollars in the first year after that broken hip. So that's the average cost to the healthcare system of the broken hip. But the thing that we need to recognize is that the absolute lowest step that we need to reach to get any of these improved outcomes is the patient has to be started on treatment. So the model that would increase the number of bone density testing, but no patient is offered osteoporosis medication, would have no possibility of decreasing fractures, decreasing mortality, or decreasing healthcare costs. So when we're going to be looking at outcomes of models going in the next few slides, we're going to be looking mostly at osteoporosis medication. So a fragility fracture after the age of 50 should prompt individuals to have a BMD and or treatment. If we stick with the major osteoporotic fractures, that were identified by the Public Health Agency of Canada. So that is hip, spine, wrist, shoulder, and pelvis. And if we restrict to patients over the age of 65, then that is a group that almost all of the patients would be indicated for osteoporosis treatment. So how are we doing in Canada? Now this is recently released by the Public Health Agency in Canada. And I'll walk you through this graph. So this goes, it's a time trend uh, um, graph, and you can see that it starts in 2000 and goes all the way to 2015. In red are the women, in blue are the men, and we're going to follow the women first. So you can see that if you look between 2000 and 2009, there's a slight increase in the rate of osteoporosis treatment within 1 year of a major osteoporotic fracture. But you can see that at the peak in 2009, only 26% of women had been offered osteoporosis treatment. If you look at men in blue, you can see that at the peak in 2009, only 17% of men have been offered osteoporosis treatment within 1 year of their birth. So you can appreciate that the care gap is huge in this instance. Less than 20% of the general public were offered treatment. And what's more worrisome is the fact that since 2009, the trend has actually been downward. And this has been a worldwide phenomenon. It's been documented in most jurisdictions that report treatment rates of fracture. So we've been looking at these guidelines for these care gaps for the past 20 years and not done anything about it. And of course, that is not so. We have been aware of these care gaps, and in pretty much all jurisdictions across Canada and worldwide, huge attempts have been made to try and close this care gap. And I'm pointing to 2010 as one of the areas where we did a major intervention at Osteoporosis Canada. We published new evidence-based clinical practice guidelines for osteoporosis. And the big focus of those guidelines were actually the fracture patients and trying to close the post-fracture care gap. You may recall that the guidelines were published in the Canadian Medical Association Journal, and so as such, they were received by the overwhelming majority of physicians in Canada. And in addition to that, there's always a huge educational component that accompanies the publication of the guidelines. So most universities did continuing medical education sessions on the new guidelines. There were new knowledge translation tools that were developed that are very clear-cut, nice algorithms, easy to follow and to understand, that help guide physicians and other healthcare providers in ensuring that they can follow the guidelines and provide the appropriate care for their fracture. Well, 2010 is when we published those guidelines, and as you can see, it has had zero impact on the post-fracture care team. So let's look at the solutions, and I put solutions in quotation marks here because it's not a solution if it fails. So we know that clinical practice guidelines, whether we look at the guidelines themselves, we look at the knowledge translation tools, we look at providing education on the guidelines, we're trying to incorporate the guidelines into routine practice, such as you might do with a clinical order set. All of these have been tried and have been done, and all of these have failed to have even the slightest bit of improvement on the care gap. If we look at education, we provide education for patients, we can provide education for family physicians and other primary care providers. We can educate the orthopedic surgeons, and we can educate the radiologists, and all of the solutions have also completely failed to have any impact on the post-fracture care day. What about a more targeted option? And I'm not going to go in detail into what we call 1I, 2I, and 3I model, but here's a targeted intervention that sends out an alert letter to the primary care provider. So Mrs. Smith breaks her wrist, and within a short time after that broken wrist, a letter goes to the patient's family physician saying, your patient Susie Smith has broken her wrist. If this was a fragility fracture due to osteoporosis, then the likelihood is very high that she may have secondary fractures imminently. You need to do bone density tests, and if needed, start them on treatment. So we have two provinces in Canada that have implemented a one-eye model like this. Um, and it's province-wide models, and they've been well-designed clinical trials surrounding that, and they have published their results. So you can see that before they implemented the alert system, you can see that the rate of osteoporosis treatment in fracture patients was extremely low in both provinces, and that is not a big surprise. So let's look now what the treatment rates are once we implement the post-fracture alert letters. So we first need to give kudos to both of those programs because this is indeed a statistically significant improvement in the rate of treatment post-fracture. However, you can still appreciate that the care gap is still alive and well in both of those locations based on this model alone. So although this is a tiny improvement in terms of meaningfully closing the care gap, these models have failed. So this is a consistent finding of one-eye model that always consistently has a small statistically significant improvement, but not a meaningful. What about trying to divide up the load? What about trying to use the existing staff within the hospitals and trying to get them to initiate the care that's needed? And this is a very nice study that was published by the Jean Talon Hospital in Montreal. They educated the orthopedic clinic nurses and the emergency room nurses who were asked to flag the fragility fracture patient and refer them directly to the medical day unit of the hospital where they had nurses specially trained to assess the osteoporosis patient and to initiate them on treatment. And in this model, only 28% of the patients ended up being managed by that osteoporosis team in the medical day unit. So where are the barriers here? Well, you realize that in the orthopedic clinic, they have very busy staff as well as in the emergency department. And so as much as the nurses were very keen on identifying all of the fragility fracture patients and getting them set up for the next step of the investigation, the fact is they're too busy. And so half of the patients were left behind because they were not identified. But of those patients who were identified, many, indeed about 30%, declined to accept the appointment. At that particular point in time, they did not feel that that was a priority for them. And of those who accepted the appointment, some of them did not show up. So you could see that there are barriers to this type of model closing the post-fracture care. So what does it take for a model to work? Osteoporosis Canada has 8 essential elements, and these are all part and parcel of the 8 essential elements, but I would say that these are the big 4. It does, and this, by the way, is based on evidence. So If a model is to be effective, there needs to be dedicated staff to do this. So it does take time to have that conversation with the patient, to educate them about their fragility fracture and to educate them about their future risk of fracture. And asking existing, very busy personnel to do this is not likely to be successful. So a dedicated FLS coordinator is a must. The model cannot wait for patients to be referred to it. So the model has to find the fracture patient. So this is called systematic and proactive case finding. And all of the FLSs will go through clinic list and the hospital admission list to identify all of the acute fracture patients coming in to the hospital. In terms of what location you need to do this in, it has to be in the right location. It has to be in a location where the fragility fracture patient typically intersect with the osteoporotic. So to do this in, for example, a rheumatology clinic is not the right location because most of the fracture patients are not going to show up at the rheumatology clinic. You need to do this where the patients are seen. So the common points are usually the emergency room or the orthopedic service. As a general comment, in the emergency room, it tends to be not as productive because the patients in acute pain, they've had some strong analgesia, their life has just been turned upside down, and so this is a life-altering moment for a patient. They're not going to hear much of what the FLS coordinator might have to say. But in the orthopedic services, that seems to be a much better location. And in fact, all of the FLSs in Canada right now are located. They do their systematic and proactive case finding in the orthopedic department, either on the inpatient ward for orthopedics or in the orthopedic center. Ideally, the model is point of care. So yes, you could do this from an administrative database and do this by phone or otherwise, but the ideal is that it's point of care, it's a person-to-person direct contact, and the patient is seen by the FLS coordinator during the orthopedic clinic appointment. It establishes a relationship between the coordinator and the patient, and it often provides a perfect spot to do point of care. So some FLSs are able to coordinate, for example, that the patient's bone density test will be done in 3 weeks' time at the same date and time that the patient's coming in to their next orthopedic clinic appointment. The other piece that the model needs to be more than just one eye. So we already looked at two one-eye models and saw the limitations of that. So the model needs to be at least twice the eye means that the model needs to initiate the investigation that are needed to determine the patient's fracture risk, and the model needs to facilitate the initiation of treatment. So if it's a two-eye model, they would make a recommendation directly to the primary care provider to initiate the right treatment. If it's a three-eye model, the FLS itself will prescribe the medication. So this is our definition of FLS at Osteoporosis Canada. You can see that it is a specific distance-based model of care for secondary fracture prevention, where a dedicated coordinator, so there is a dedicated personnel, does systematic and proactive case finding at the hospital, does the investigations to determine the patient's fracture risk, and does facilitate that the patient gets initiated on the appropriate osteoporosis. Now, again, we have a full webinar looking at the effectiveness of the FLS model of care, but just to summarize, FLS increases the rate of DMD testing, increases the rate of initiation of osteoporosis treatment, it improves treatment adherence, it reduces the refracture rate in patients and it reduces mortality. And this is based on a meta-analysis that was published last year. So, no controversy about this. FLS works. But of course, we need to hire an FLS coordinator. So, what does it do in terms of cost effectiveness? Well, there have been numerous cost effectiveness studies published of fracture liaison services. When the model is 2I or 3I, very consistently, the model is not only shown to be cost effective, it's actually shown to be cost saving to the system. So let me just explain what that means. It means that even after you have paid for the salary for the FLS coordinator, and even after you have paid for all of the extra bone density tests that have been performed, and all of the extra prescription drugs for osteoporosis that have been given to patients, even after paying for all of this, the model still costs less than no FLS or status quo because of the reduction in the number of customer fractures. Remember, if you prevent just one single broken hip, you've actually saved the healthcare system in the order of $60,000. So you can do the math. You don't need to prevent that many broken hips that you've now paid for the full-time FLS course. Most FLSs that have done cost-effectiveness studies can show a break-even point starting at about 2 to 4 years. And after that, it's cost saving. So it's paying dividends. So based on the overpowering evidence that supports FLS and the fact that it makes so much sense because it is cost saving to the healthcare system, when we first launched our FLS toolkit in 2013, we said right up front, all jurisdictions should implement FLS by 2015. It seemed so logical. The ask seemed so small that we all felt that this would happen very rapidly. So how are we doing on that? Well, it turns out we're not doing so great. We have at Osteoporotic Canada an FLS registry. It is a voluntary registry, but Canada and the osteoporosis community in Canada is a pretty small community. And we are aware of about a handful of FLSs at most who have chosen not to submit to our registry. So most FLSs are on this registry. We need hundreds of FLSs in Canada. How many do we have in total currently? Well, we currently have 43 FLSs. Five provinces have FLSs. BC, Alberta, Ontario, Quebec, and Nova Scotia. So that means that 5 provinces have zero access to any FLS. And none of the provinces that are listed here have full coverage for FLS. So I'll give the example of BC. BC has 4 million population. It has 1 single FLS. Obviously, there needs to be countless more FLSs in BC. So it's just a drop in the bucket. In terms of the scope of the FLS, to identify all the patients, an FLS really needs to identify the admitted patients because that's where you find the hip fractures. Not all hip fractures return to the outpatient department. So if you do outpatient, if you do the proactive, systematic and proactive case finding only in the outpatient department, then you're leaving behind a substantial proportion of the hip fracture patients. So ideally, an FLS is covering both the inpatient orthopedic services, so that you can capture the majority of the broken hip, and also should cover the orthopedic clinic so that you can capture the majority of these wrist and shoulder and pelvic fractures, for example. Well, it turns out that in Canada, most FLS are underfunded. And so most hospitals which have an FLS have only either inpatient FLS or outpatient only FLS, not both. But even beyond that, for example, at an FLS that would, at a hospital that would have an outpatient only FLS, the fracture volume at that hospital might be such that we know that they need one full-time FLS coordinator. However, the hospital, in their infinite wisdom, has decided to only allocate a half-time position to that FLS coordinator. And so, therefore, even in the outpatient department, half of patients are still being left behind. So, can we estimate what proportion of the fracture patients in Canada currently have access to an FLS? And we have been able to do that based on the enrollment data from the FLS. And we know that currently less than 15% of Canadians who present with a major osteoporotic fracture, and here we are specifically excluding the spine fractures, so our denominator is even smaller, or less than 15% have access to an FLS. So that's giving you the enormity of the post-fracture care gap in terms of accessing the one and only model of care that can actually start to have a major impact on closing the post-fracture care gap. So why is it? What's the barrier? Well, it can be summed up to that one single thing. To do an FLS, you do need that dedicated personnel, and that does mean that someone, and to be sustainable, and it has to be government, will have to hire the FLS coordinator. So what are the barriers to that? Well, first of all, I want to say, put things in context and show how tiny of an ask it is. So it's both a huge mountain that we cannot climb, and yet it's such a tiny, tiny little molehill. So if I use Nova Scotia as an example, the Nova Scotia Health Authority employs greater than 20,000 employees. If I compare to diabetes, I've counted, it's listed on our website, we have 35 diabetes centers in Nova Scotia. So how many FLSs do we need in Nova Scotia? We need 5. 5 FLS. One of those hospitals has a super high volume of fracture patients and would need 2 full-time FLS nurses. So our ask is for 6 full-time FLS nurses. You can see that it is such a tiny ask in the grand scheme of things when you look at the entire healthcare as a whole. But yet, in the current environment, hiring just one single new employee is almost impossible. So let's look at some of the challenges and the big barriers to FLS implementation. And I've split them into 4 different themes. So there's lack of awareness of osteoporosis. There's no home for FLS in the current healthcare system in Canada. As you all know, but governments are mostly in cutback mode, and so there is no new money for a new staff system in the healthcare system. And then there's ignoring the evidence. So let's start with the first one. We often say that osteoporosis is not a sexy disease. It tends to affect older patients. And it's a poorly recognized disease, both in the lay public and quite often in healthcare administrators. Not all healthcare administrators have a background as a healthcare professional. So we often see that there's confusion between osteoarthritis and osteoporosis. And of course, Both of those are completely different diseases. But it is not unusual for some of our FLS champions to meet with a healthcare administrator, make their pitch for an FLS, and at the end of the conversation when they're leaving, the administrator says, well, I'd love to help you, but we've already started a new program for osteoarthritis, so obviously we're not going to be doing yours as well. So they do not understand the difference between the two diseases. So you can imagine that a lot of time when we want to start that conversation with the healthcare administrators, it starts by even starting by educating them about the basics about osteoporosis. We also cannot compete with diseases like cancer, and diabetes, and heart disease. So for one thing, none of those diseases do you have to explain to the healthcare administrator what that disease is and the impact that this has very negatively on patients. But I think those types of diseases just bring fear of most individuals. So I think it's poorly understood how severe and serious osteoporosis is. And I'll use the example of the broken hip. The broken hip is a life-changing moment for most patients. Less than half will ever recover the full level of injury that they had prior to that broken hip. For 1 in 5 of them, it will mean that they no longer can cope in their own home and will need to be transferred to a nursing home. There's a huge mortality impact of a hip fracture. 23% of women and 36% of men will die within that first year after the broken hip. So osteoporosis is not a benign disease. It very much belongs to the other fear uh, causing diseases like cancer, diabetes, and heart disease. In terms of the other aspect, when we meet with healthcare administrators, most healthcare administrators do not recognize or are not aware of the huge cost of osteoporotic fracture. Their picture of a fracture is often, oh, broken wrist, you cast it, and off the patient goes. I've listed here some of the average costs for hip fracture, and of course I haven't included all of the components of care here, but the total cost for that broken hip on average in Canada is $63,000 in the first year after the broken hip. It's a huge cost burden to the healthcare system. So imagine how much we could save the system if we could just prevent acute broken hips. What about what I've been stating, that there is no home for FLS? Well, in the current healthcare infrastructure, there is no FLS, so there's nobody that has FLS in their portfolio. We're adding this to somebody's portfolio, but even worse, there's often typically not even osteoporosis in any healthcare administrator's portfolio. So I will use the example of the 3 locations in Nova Scotia where we have a fracture liaison service. So that would be Kentville, Dartmouth, and Sydney. And at those 3 hospitals, there's not even an osteoporosis clinic there. So you can see that there isn't a healthcare administrator at those hospitals that you can go knock on their door and say, you know, this is part of osteoporosis, and can we see about setting up an FLS? Because no one has osteoporosis in their portfolio. So typically our FLS champions, they have a little bit of a dance to do. So they go see healthcare administrator A, the smart administrator, and they'll say, of course, I get this. We really need to make this happen. But unfortunately, this is not in my portfolio. I would suggest you go see healthcare administrator B. You get the same song and dance from B, who says go see administrator C. And next thing you know, they're recommending that you need to go back to A. So that's one of the bands that we run around because it's not in anybody's portfolio. Very hard to find someone who will take this on. But over and above that, if you're working in Canada these days, you know that in most provinces, there's pretty massive healthcare restructuring. So that means that even if you do find that very smart and courageous healthcare administrator is going to make FLS happen, it's not unusual that all of a sudden, because of the restructuring, that entire department is now no longer running. That healthcare administrator has now been assigned to a new portfolio, and you have to start the dance from scratch again. So you can see how this is a huge challenge to getting healthcare administrators to step up to FLS in the first place. You can't find it at home. Now let me give you another illustration as to the fact that there's no home for FLS. If there was a logical home for FLS, anywhere that there's an FLS, it would be actually parked under the same portfolio. So for example, if you look at, orthopedics, they've always been parked under surgery. That's kind of the logical thing. But for FLS, it's not so logical. And I'll apologize in advance if some of these things have changed and I'm not giving the current information, but I can give you the current information for Nova Scotia. So FLS is felt to be part of chronic disease management, which of course it is absolutely good to care. So it falls under primary healthcare portfolio at Nova Scotia Health Authority. In Quebec, there are three FLSs, they're independent FLSs, and there they got the hospital itself to orthopedics to cover the cost of the FLS coordinator. In Ontario, the most of the FLSs fall under the Ontario Osteoporotic Strategy, and those strategy FLS coordinators are not employees of the hospital. They're not employees of the LHIN or the equivalent of a district health authority. They are actually employees of Osteoporotic Canada, and that's because in Ontario, the Ministry of Health and Long-Term Care decided to give that contract out to an outside agency, Osteoporotic Canada, to manage the FLS. So in terms of where does that get parked in the healthcare system, it's parked outside of the healthcare system, so to speak. In the one and only FLS in BC, I would say they did some acrobatics in terms of funding the FLS coordinator. So the FLS coordinator, at least a couple of years ago, was funded through primary health care. But the FLS medical lead who happens to be a family physician, could not find funding in primary health care, and part of the funding came from geriatrics. So it tells you the kind of acrobatics that have to be done to find funding. Now, I'm going to go over the next rule, which is no new money in the healthcare system, but there was one exception to that rule, and that was Alberta. And I think that is the ideal situation that we see in Alberta. In Alberta, they have a fund of money to help support new innovations in the healthcare system, and that's managed by a network called Strategic Clinical Network. And there's one for bone and health, bone and joint health. And because they looked at the evidence and saw the overwhelming evidence in support of FLS, they are supporting FLS, and they're starting with hip fracture FLS for inpatient, and that is covered from the Ministry of Health, but funneling to but that Alberta situation is the exception. In most provinces, we always hear there is no new money in the healthcare system. And so consequently, to hire that nurse is difficult. So I want to go over a little bit what it means when we say that the FLS will face the system line. So if you look at the blue line here, this is the number of hip fractures keep going up as the population is getting older over time. And so without FLS, that will go unimpeded, and the cost at $60,000 a hip fracture will keep going up as the number of broken hips goes up. With FLS, you will actually spend that time. Okay, so you're reducing the cost, but there's still cost to hip fracture. And additionally, to the healthcare administrators themselves, the cost savings are not cost savings. So what are the cost savings? The cost savings are because you prevented a broken hip, you saved an OR for that patient, you saved an admission to hospital, and you've also averted potentially an admission to long-term care. But to the healthcare administrators, that bed that you just freed up from the preventive hip fracture is just going to be filled up by double knee replacement. And that nursing home bed that was going to be filled up by the hip fracture that you just prevented will now be filled up by an outlier. So we don't, although in cost and health economics terms, talk about cost savings, in a healthcare administrator's term, we talk about cost avoidance. And for some healthcare administrators, cost avoidance is totally meaningless. They're not going to really reduce their budget by anything. They're not going to really avoid any cost. And so FLS, despite being so cost effective, it's not going to be something that they're going to look at, and that is short-sighted. The fact is, FLS is value-based healthcare. And Canadians do want healthcare that improves patient outcomes, and FLS does that in spades. FLS will free up those scarce ER beds, the orthopedic beds in the hospital, free up the anesthesiologist for the OR for that procedure. Long-term care beds will be saved, less pressure on home care. It allows those resources to be redeployed to help other patients. It is a much more efficient use of the existing healthcare resources. So it should matter, but not all healthcare professionals or administrators have that longer term vision about what needs to happen in the healthcare system. So finally, I'm going to get to this. This is a very common thing that we see, but the evidence is ignored. So here you are. You are in a situation where you have a team at the hospital that are all fully bought in. You need an FLS. You've convinced your healthcare administrators that this needs to happen, but you're stuck. There is no new money to hire the FLS coordinator. So those very caring individuals have a choice then. They can either do nothing at all, or they can do a little something. And so this is what they will fall back on. They will circulate the Osteoporosis Canada clinical practice guide. They will educate their patients. They will provide education for the family physicians. They may educate their emergency room physicians and their orthopedic surgeons. They maybe even go out and send out alert letters to the family doctors. They may ask their very busy emergency room staff or orthopedic staff to help identify the fragility fracture patients. You've all heard those examples already listed in this presentation. And you already know that these are futile efforts. But I see this repeating itself across the country. It's that feeling that you just simply cannot do nothing. But here's the thing. Doing these things They all cost money. They all use resources within the healthcare system. So doing a little something is not always better than doing nothing at all. And let me tell you that there's another big issue. Once you implement the model, even if it's a model that's going to be doomed to failure, once you implement the model, you are raising everybody's hopes and expectations that your model might actually improve the post-fracture care gap. And as a general comment, if you're doing this correctly, it will take about 1 year to plan that new ineffective model because people need to sign off on it. You will spend 1 year implementing it. If you're doing this correctly, you will also want to evaluate it. So add an extra year to evaluate. It may take 3 years, and all of that time, you're taking any possibility of implementing a true effective FLS at that hospital. Because everybody is pinning their hopes on a model that we already know based on evidence will be doomed to failure. So the evidence is overwhelming. FLS does improve appropriate care. It decreases secondary fractures. It reduces mortality. It reduces healthcare utilization and costs. We've already talked about it, right? We are not doing so well. We have very sparse FLS in Canada right now, more gaps than not. It's a very small ask for the healthcare system, but it does need someone to act. And hopefully, if we do all that, we'll eventually end up with enough on. So let's focus on what it means that FLS champions like yourself might take this on. Well, I do not have a magic bullet. If I had a magic bullet, we'd have hundreds of FLSs in Canada right now. But I can tell you what I've things that unite those hospitals where an FLS has been used. So first off, there has to be an FLS champion. Someone has to ask for the FLS. If nobody asks, it will never happen. One single FLS champion by themselves, that's a pretty hard thing to do. It needs to be supported by an entire team, typically a multidisciplinary team. The team must get together and be very clear on what their ask is, and Osteoporosis Canada can actually help you with that. You need to know what type of FLS you're asking for. Are you asking for a complete combined inpatient and outpatient FLS? Are you going, for example, for just inpatient only FLS? For the type of FLS, what are the FTE requirements for the FLS nurse? You need full-time FLS coordinators or part-time FLS coordinators. But no, even if you have all of this correctly, I can guarantee that a single meeting with one single healthcare administrator is not going to win. What unites all of the hospitals that have an FLS right now is that the FLS champions have a extremely perseverance. They go at it, and they go at it, and they go at it. And eventually, they happen to be at the right place at the right time, and they get success. So here we are right now with all of these gaps, and my hope is that we'll eventually end up with a registry map that will look a lot more like this. So at this point, I'll take your questions.
Hi, everyone. So if you can write your questions into the question box, I will be sure to pass them along to Diane. Thank you, Diane, for that very interesting overview and the call to action that hopefully our listeners will be able to enact at their own sites. So we'll give it a few minutes for you to jot down your questions to me. And again, if you can't put the questions in, if you have to run, then there will be a survey that will show up in your inbox by tomorrow, and you can put your questions in those, and I will be sure to pass those along to Diane. So I don't see anyone typing. I don't see any questions coming. So on that note, I will say thank you, Dr. Theriault, for sharing your knowledge and your encouragement with us. And we will join in together and learn more about FLS another day. Bye-bye, everyone.